Hi everyone, welcome to ACE ISC Psychology. Today, we will be starting Chapter 5 of Class 12, Psychological Disorders and Psychotherapy. This is one of the most interesting chapters as it introduces you to clinical psychology and the work clinical psychologists do in real life. It has many disorders, each with their own causes, symptoms, and treatment plans. So to make it easy, I have broken it up into subsections. In today's first part, I will introduce the DSM-IV and start with anxiety disorders. As always, I will be giving important ISC exam tips to help you prepare and score in board exams, so stay tuned till the end. Before we study a disorder, we have to answer a much harder question first. What actually counts as abnormal? It sounds simple, but psychologists have struggled with this for over a century, because abnormal is not just different or unusual. A left-handed person is statistically unusual. A genius is unusual. Neither is abnormal in the clinical sense. So, in this video, I will introduce the foundation of the entire chapter, the meaning of abnormal behavior, the different ways psychologists have tried to define it, and the classification system, the DSM-IV, that clinicians use to diagnose disorders. Psychologists agree that abnormal behavior tends to share four common features. Together, these are often remembered as the 4 Ds. Deviance, which means the behavior deviates or departs from what society considers normal or acceptable. This is culturally relative. A behavior considered deviant in one society may be perfectly acceptable in another. For example, hearing voices might be seen as a symptom of a disorder in one cultural context, but as a spiritual experience in another. Distress. This refers to the emotional suffering the behavior causes, to the individual themselves or to people around them. Someone with an anxiety disorder is not just different, they are genuinely suffering. Dysfunction, which means the behavior interferes with the person's ability to function normally in daily life, at work, in relationships, or in self-care. This is often the clearest sign to clinicians because it's observable and measurable. Finally, danger, which refers to behavior that poses a risk to harm, to the individual themselves or to others. This is one of the most serious of the four and often triggers urgent clinical intervention. So in your exams, examiners often ask you to explain the 4 Ds with examples as a 4-mark question. Students very often name 2 or 3 and forget danger entirely because it feels less common in everyday examples. But make sure you write it all 4 and even explain them briefly. Now that we know the common features, let us look at how different approaches in psychology actually define and explain abnormality. There are 3 broad views you need to know. The first view is the statistical stand. The statistical stand defines abnormality in terms of how far a person's behavior deviates from the standard average or norm of the population. If most people fall within a certain range on a trait, say anxiety levels, then someone far outside that range in either direction is labeled statistically abnormal. The problem with this view is that being statistically rare does not automatically mean something is unhealthy. Extremely high intelligence is statistically rare, but we would not call it abnormal in a clinical sense. The second medical or biological approach treats abnormal behavior like a physical illness, something with an underlying biological cause, like genetic factors, chemical imbalances in the brain, or damage to the nervous system. This view treats disorders as diseases that can be diagnosed and treated medically, like physical illnesses. The final view is the psychological perspective. This looks at abnormality through the lens of mental and behavioral processes, rather than the biology or statistical angle alone. This view actually contains 4 distinct sub-perspectives. Number 1, psychoanalytic. Abnormal behavior arises from unconscious conflicts, often rooted in early childhood experiences. Second, behavioral. Abnormal behavior is learned through the same processes as conditioning, both classical and operant, that produce normal behavior. Third, cognitive. Abnormal behavior results from distorted irrational, or maladaptive patterns of thinking. And finally, sociocultural. Abnormal behavior is shaped and defined by the social and cultural context a person lives in. What's abnormal varies across cultures and social settings. This is a classic explain the different views of abnormal behavior essay question, which usually comes for 5 or 6 marks in exams. Students often merge the biological approach and the psychoanalytic subpart by mistake, or forget that psychological perspectives is actually 4 separate viewpoints, not just one. So remember to structure your answer as the following. Start with statistical, move on to biological or the medical approach, and finally talk about the psychological perspective, which lists all 4 subtypes. Once psychologists agree that abnormality exists, the next question is how do we organize and categorize the different types? This is where classification systems come in. Classification is necessary because it allows clinicians to communicate using a shared, standard language, helps in choosing the right treatment approach, and allows researchers to study specific disorders systematically. It also helps predict how a disorder is likely to progress. The most widely referenced classification system is the DSM, the Diagnostic and Statistical Manual of Mental Disorders, specifically the 4th edition. So what is the DSM-IV? The DSM-IV does not just give a disorder a name. It evaluates a person across 5 separate dimensions called axes. This is a multimodal axial system because it looks at the entire whole picture, not just one symptom. The first axis is axis 1, clinical disorders. This covers the major clinical syndromes, the disorders you will be studying for the rest of this chapter, like anxiety disorders, mood disorders, and schizophrenia. Axis 2 deals with personality disorders and mental retardation. This covers long-standing, deeply ingrained patterns, personality disorders like antisocial or dependent personality, as well as intellectual disability. Axis 3 is general medical conditions. This records any physical health conditions that might be relevant to understanding or managing the person's psychological state. For example, a thyroid condition that affects mood. Axis 4 is psychosocial and environmental problems. This covers external stressors in the person's life, things like job loss, family conflict, or housing problems, factors that may be contributing to or worsening the disorder. And finally, Axis 5 is Global Assessment of Functioning, or the JAF. This is an overall rating of how well the person is functioning in daily life, usually on a numerical scale, giving clinicians a snapshot of overall severity. One important exam tip. Briefly explain the 5 axes of DSM-IV is an almost guaranteed question from this chapter, usually which comes for 5 marks. The biggest mistake students make is mixing up axis 3 and axis 4. Remember, axis 3 is physical and medical, while axis 4 is social and environmental. Before moving on, I want to draw your attention to 3 key things you must do while preparing for your exams. First, high-yield areas, or the important focus areas that you absolutely must study. The 4 Ds, they are always asked either alone or combined with the case study identification question. The 3 views of abnormality, especially the psychosocial perspectives with all 4 subtypes, and the 5 DSM-IV axes explained individually. Where students lose the most marks is writing abnormal behavior definitions in vague, everyday language instead of using the 4 Ds framework. Secondly, treating psychological perspectives as one single view instead of 4. And finally, confusing axis 3 and axis 4. So you need to list all the axes with explanations instead of just naming them, because bare lists will not earn you full marks. And finally, I want to draw your attention to what you must avoid doing in this chapter. Do not memorize the 4 Ds and axes as isolated lists. Link each one to one-line examples so you can apply them to case study questions, which are very common in exams. Do not skip the Why Classify Disorders section. It is short, but it appears as a standalone 2 to 3 mark question almost every year. And finally, Do not confuse this DSM-IV framework with the disorder-specific content that will be coming later. This section is the classification system, not the disorders themselves. Now we will start with the disorders section. We are going to look at 3 anxiety disorders from your syllabus: Generalized Anxiety Disorder, Phobias, and Obsessive-Compulsive Disorder. This is a very applied clinical section, so we are now looking at real diagnostic categories, so do pay close attention to how each disorder is defined and what distinguishes it from the others. Let us start with the situation. Everyone feels anxious sometimes, before an exam, before a big decision, or a big event. And that's normal, even useful anxiety. But for some people, anxiety stops being an occasional response to stress and becomes a constant, disabling condition. That is the difference we are going to be exploring in this section. Generalized Anxiety Disorder, or GAD, is exactly what the name suggests: anxiety that is not tied to a specific object or situation, but is generalized across almost every area of a person's life. People with GAD experience persistent, excessive worry about everyday matters, like health, work, finances, or relationships, even when there's little or no reason for concern. This worry is difficult to control and is accompanied by physical symptoms like restlessness, muscle tension, fatigue, irritability, difficulty concentrating, and disturbed sleep. The causes of GAD are typically understood as a combination of factors. Biologically, there may be inherited predisposition, along with imbalances in neurotransmitters involved in regulating mood and anxiety. Psychologically, a pattern of chronic negative or catastrophic thinking plays a major role, constantly expecting the worst outcome. Environmentally, ongoing life stress or a history of stressful or traumatic experiences can also contribute to its development. The key distinguishing factor of GAD that examiners look for is the word generalized. It is not about one object or situation. It is free-flowing anxiety across multiple areas of life. So if a question gives you a case study of a person worried about everything, that is your cue to identify GAD. Next, we come to phobias. Unlike GAD, a phobia is an anxiety attached to a very specific object or situation. A phobia is an intense, irrational, and persistent fear of a specific object, activity, or situation that is disproportionate to the actual danger it presents. The core symptom of a phobia is this: excessive fear response, which can include physical panic symptoms like a racing heart, sweating, and shortness of breath, triggered specifically by exposure to or even the anticipation of the feared object or situation. Crucially, the person typically recognizes that their fear is excessive or unreasonable, but is still unable to control it, and will go out of their way to avoid the trigger. Phobias are often explained through learning-based causes. A phobia can develop through classical conditioning, when a neutral object becomes associated with a frightening or traumatic experience. It can also develop through observational learning, watching someone else react fearfully to an object and adopting that fear response. Biological predisposition can also play a role, making certain individuals more prone to developing intense fear responses. Examples of phobias include fear of spiders, fear of closed spaces, called claustrophobia, and also agoraphobia, which is a fear of going outdoors. Students often lose marks here by only defining phobia generically, without giving the 2 defining features that examiners look for. That is, the fear is disproportionate to actual danger, and that the person recognizes it as irrational but cannot control it. So always make sure to include both points. Finally, we come to Obsessive-Compulsive Disorder, or OCD. I'm sure many of you have heard about this before, but it's very different to the usage in everyday life and clinical contexts. OCD is often misunderstood as simply liking things clean and organized. In reality, it is a specific and distressing disorder built on 2 connected components: obsessions and compulsions. Obsessions are recurring intrusive thoughts, images, or impulses that the person cannot control and that cause experience anxiety. For example, a persistent fear of contamination. Compulsions are repetitive behaviors or mental acts that the person feels driven to perform, usually in response to an obsession, in an attempt to reduce the anxiety it causes. For example, excessive hand washing in response to a contamination obsession. The key symptom pattern is this obsession-compulsion cycle. The obsessive thought creates anxiety, and the compulsive behavior temporarily relieves that anxiety, which again reinforces the compulsion, and the cycle repeats. This cycle can become extremely time-consuming and significantly interfere with daily functioning. Causes of OCD include biological factors, like abnormalities in specific brain circuits and neurotransmitter activity. Psychologically, the behavioral perspective explains the compulsive behavior as being negatively reinforced. Because it reduces anxiety, the behavior is repeated. Cognitive factors, like an inflated sense of responsibility or a tendency to overestimate threat, are also considered contributing causes. The most common mistake in OCD answers is describing only the compulsion, the visible behavior, like hand washing or shutting the door, and forgetting to define the obsession, that is, the underlying thought that drives it. Examiners specifically want both halves of the circle explained, and the reinforcement link between them, that the compulsion reduces the anxiety the obsession creates. Now that we've covered the anxiety disorders, this is a quick, helpful reference guide for you to compare all three disorders and see the triggers are different, how the scope is different, and how their core systems are different. This is a very helpful reference guide, especially for revising before exams, so make sure you take a screenshot and note it down. I also want to draw your attention to important ISC exam tips and focus areas. There are some very important areas that you absolutely must focus on from this chapter. First, distinguish between the three disorders from each other. Understand their key symptoms, their triggers, and how they are different from each other in their cycles. Because in case identification questions, this will often be important. You will be given a short scenario and asked to name and justify which anxiety disorder it describes. So it's very important that you understand and memorize the key elements of each. The obsession versus compulsion distinction within OCD is also a very important area for you to specifically understand and memorize. Where students lose the most marks is confusing GAD with phobia and writing a fear of everything for phobia when phobia must be tied to a specific trigger. Again, OCD answers that describe the compulsive behavior only without the explanation of the obsession behind it will not give you any marks. Giving symptoms without causes or causes without symptoms is something that examiners frequently award marks separately for. So a one-sided answer, that is forgetting to write at least the causes or the symptoms, will only give you half marks. Again, remember not to write vague one-line answer for causes. Always structure causes across at least two categories, for example, biological and psychological, rather than listing one cause and then stopping. So, important tip to remember is that whenever you're asked for causes for any disorder, you need to structure your answer by giving the causes like biological or psychological instead of just listing one. And finally, what to avoid while studying from this chapter. Do not study these three disorders as a single list. Build a clear comparison table for yourself with triggers, symptoms, and causes so you can tell them apart instantly under exam pressure. Do not skip memorizing the obsession-compulsion cycle for OCD. A diagram-style mental model is often something that's helped a lot of students. And finally, do not confuse the causes of a specific anxiety disorder with the general perspectives. That's all for today. In the next video, we will cover mood disorders and personality disorders. Until then, please do like, share, and subscribe to our videos, and stay tuned for the next one.